Liebe Kolleginnen, liebe Kollegen, mein Name ist Dr. Ulrich Volz, ich bin zahnärztlicher Leiter der Swiss Klinik.
Colleagues, I'm Dr. Ulrich Volz. I am the leading dentist at the Swiss Biohealth Clinic, the leading clinic for biological dentistry in Kreuzlingen, Switzerland at the Lake Constance. With my webinar of 45 minutes of the Swiss Biohealth Clinic, I would like to present to you the basics of our treatment concept. And I would like to show you the role of ceramics implants in this concept. The way towards biological dentistry with ceramic implants. Well, this is in line with what Steve Jobs once said. We take care of the real huge problems. We offer an absolutely effective solution with our all-in-one concept. And with this, we generate a really great demand. I will present to you a case now. A patient who came to our clinic around 2.5 years ago. On the left upper side, we see a metal chip that was removed together with the Nikos, the neuralgia-inducing cavitation osteonecrosis. You see here the metal sleeves, 16 implants were set. A copy of the Prosthodontics was created, filled with Luxatemp, and then fixed long-term temporary was inserted. And now let's hear what the patient says directly 2 days after the surgery with a sinus lift on both sides. And when you listen to the patient, then you see the options of this concept, not only with regard to dentistry, but also with regard to the overall medical treatment to achieve an improved health state.
Heilpraktiker, alter Klingenhautschläfer, so Operation hinter mir vor 2 Tagen. Und die Veränderung war, das ist sensationell. Ich habe eine Nico rausbekommen vor 2 Monaten, links, dadurch wurde meine Sehkraft extrem gestärkt wieder. Und gestern bei dem Entfernen von den Metallkappen, den Goldkappen, habe ich ein sehr, sehr angenehmes Gefühl bekommen im Bauch. Mein Bauch hat sich wieder richtig frei. Weiterhin sind meine Schultern voll beweglich, wo ich bis jetzt immer Probleme gehabt habe. Und seit 15 Jahren, seitdem ich diese Goldgeschichten im Mund habe, habe ich immer Kopfschmerzen gehabt und die sind weg. Und ich kann jetzt plötzlich wieder aufrecht stehen. Vorher war ich immer so zusammengezogen und jetzt stehe ich wieder ganz normal und aufrecht und die Schultern sind frei. Ist einfach super. Also allein von den körperlichen Auswirkungen hat sich das gelohnt, abgesehen von den Zähnen.
The patient laughs at the end. Why? Because for 1 minute he talks about improved symptoms in the medical area, and then at the end he remembers, oh yes, I also went to the dentist and something was done at my teeth. And when you take a look at the pictures here, especially after the final restoration, then you see a significant improvement of his appearance. So here you see how the final restoration is set 4 months later. Then we have a zirconium oxide-based super construction. And this is how it was documented. You see that all implants healed in. Another case of a patient. She suffered from MS and Lyme disease. She had 2 thumbs, frozen thumbs. She couldn't move them at all. She could only make really small steps. And this was the situation that you saw on the X-rays. We made some sections through the X-rays. You see really low Hounsfield units. That means no spongy bone left anymore. And here you see huge defects, fatty cysts that we removed on the right bottom, a really huge cyst. We filled it up with PRF. 4 months later, the patient came back. We did the abutments, the formed parts, and interestingly, not all implants healed in, but the bone also regrew. And when you take a look at the patient, she looks much younger, her eyes are wide open now. And this is the testimonial by the patient. She says here that very quickly she could move her shoulders again and her thumbs. She felt more energy. Her muscles and joints didn't ache. She could go for a walk with the dogs and the horses. Her brain felt better and her anxiety decreased significantly. What does the concept look like? We have the point of surgery 4 weeks before to 4 weeks later. We give basic immune supplements. It's a supplement mixture that we developed together with Dr. Klinghardt, our head of the medical department here. The patients should come 1 day before the surgery just to relax a bit, to arrive, stay for at least 4 days, because in case there are complications, then normally these complications happen always within the first 3 to 4 days. And then we can support the patient, ideally, in case there is a complication, but the risk is anyway close to zero. 2 weeks before to 2 weeks later, the patient should do without dairy products, animal protein, sugar, starch, alcohol, smoking, and often underestimated Wi-Fi and cell phone radiation, because we know that this brings the patient to the stress mode, the sympathetic mode, and then the body cannot heal. We know that. So the nutrition should be as marked in green: vegetables, nuts, but no peanuts, avocado, coconut, or smoothies, broth. Actually, it is anyway better to stay to this protocol, not only 2 weeks before and after the surgery, but in general. So we call this My Biohealth Week, that the patients stay here with us. What is a basic immune? There are 2 versions, morning and night. In morning, you get energy. This is why we call it like that. And magnesium, for instance, is contained in the night mixture because it makes you tired. So when you travel, you don't have to bring along 20 different boxes and follow a complicated protocol, but we can just take these sachets. So let's hear what Professor Simon Pieri says about our implant shapes. After he made the first surgery, immediate implantation, 8 ceramic implants. Together, you see him on the left, Professor Chakroun, the developer of the PRF membrane technology.
Listen, it's my first time I use these implants in ceramic, and it's just amazing about sensation. It's completely different about drilling, and about also when you place implant, the implant comment il glisse. It's very smooth. Smooth, you know, in preparation. It's just amazing implant, honestly, and it's also very beautiful, because I think for the soft tissue is fantastic. I hope we will obtain amazing results.
Yes, this was directly after the surgery, and here you see the X-ray, absolutely nicely set parallel implants of the 8 implants. Dr. Simon Pieri is well known for that. And some weeks later, He sent me this picture of the long-term temporaries. 3 to 4 weeks later, everything healed in nicely. He has now published this case, everything healed in, and the final restoration has also been placed. Let's take a look at what is so special about zirconia oxide. What you see here is human histology after 25 years in the patient, of course not done by me, but my colleague Dr. Rudelt, who made a study between Hamburg-Eppendorf and the University of Tokyo. He made the study with zirconia oxide implants and made some block histologies. And when you take a look at the bone implant contact, then you see a fantastic result. I would like to draw your attention to the close attachment of the gingiva to the zirconia oxide. Zirconia oxide is the only known material that is able to combine with the gingiva. Gingiva is the ectoderm, the bone is the mesoderm. And if this connection is not closed, as it is for the natural tooth, then we have an open gate. And in the blood cloth, when you have a heart attack or brain attack, the same pathogens are found as in the oral cavity. So this is a kind of a wide open door for the Trojan horse. It's a biologically open gate. So for titanium, which is a material that does not combine with gingiva or bone, the biological gate will be open your whole life. And for zirconia oxide, that works even better than the natural tooth, this biological gate will be closed. Let's take a look at this study that I wrote in 2000, that I made in 2006 when I wrote my PhD thesis. 89 patients, 3.5 years, and with only one outlier, there was no sulcus bleeding index. Compared to natural teeth that have an SPI between 10 to 15%. So the implants heal in. When we remove the final restoration, then you see how the implants are placed at the highest point of the papilla. And due to the tulip shape, the implants can be ground in a way so that we are exactly on the gingiva level. I am sure that you will not disagree that there's nothing healthier than a one-piece implant where the edge is exactly at the gingiva level. This situation can not be achieved with any bone-level implant, with any implant where the crown is on the abutment and where you have a gap below the gingiva or even on the bone level. Let's take a look at this situation. Here we learned a lot for the future, the so-called bone-growing implants. This is a case where after extraction, I did not implant on the current as-is state, but on the target to be state. You see that here. Only 3 to 5 millimeters inside the bone. And you see the very nicely attached gingiva that is closed. With the suture, we also inserted a splint. And 2.5 months later, you see the final restoration. The gingiva is not completely healed. than the crowns. And when we take a look at that, then you see that the bone grew up until or up to the tulip. This is a biological principle that we have been using in dentistry for decades. This is a study by Hammerle et al. They set so-called tent poles, and the periosteum is kept at a certain distance. We know that the balls here would not have been necessary because the effect comes from the periosteum. The membrane would also not be necessary. So here it worked not because of the membrane, but despite the membrane. Actually, the membrane wouldn't have been necessary. We know today that we just have to use osteosynthesis screws and then new bone will grow in. And the bone that we see here is the best bone that we can wish to have, better than any bone block or bone that was generated by bone replacement material, because it's 100% natural own bone that also contains vascularization. We know that any tissue, heart, brain, lungs, skin, whatever, is mainly dependent on vascularization. The better vascularization, the higher the probability that this tissue works the whole life. Whenever you have a defect in the tissue, this is, of course, an obstacle for lamellar bone, as you see it here in this picture. Based on this knowledge, we developed the concept further. Here you see a huge defect with the facial perspective here, and the next is the cross section, and after extraction you see just the vestibular wall was left, the palatinal wall around the implant to give it apical stability. You see a bit of a sinus lift with the osteotome, and the implant is completely free here. There is no contact to the neighboring walls. Only via the aggressive apical section it is anchored, fixed. We filled everything up around with PRF, and this is a concept that follows the idea of Simon Pieri and Chacroun. This is the Kakashi technique, where discs of extracted teeth are put on the alveole. In this case, we do not take discs of bone, but made of zirconia oxide. We adapt the discs to the size of the defect. And in addition to the tent pole, that means the implant, we put this big parasol on top. And this is the picture the lady sent some months later from the US, so it looks quite promising. Here, the overall case, you see directly post-op the image, and here you see that the bone regrew. The 2-6, that was done in one session, from extreme defect on a threatening sinus lift up to a perfect bone situation. And now also with the corresponding fine restoration. Here you see once again the tent pole and then the later crown. Based on this knowledge, we experimented with different shapes. In this case, it's a balcony implant, where the implant is used as a tent pole in the alveole, but we put on top a parasol over the buccal alveole. When the patient comes back, this is what it looks like. Vestibularly, we don't see any problem. You won't have any problem with any food residues in any gap. The same works also in the mandible with balcony implants. And another case here that shows how we can use these balcony implants without having to drill. Here the alveole was anyway big enough that the burrs fit. So we use the Summers osteotome and apically over the 2 millimeters. The apical section is used for the stability, so the movie is a bit faster in real time. We have 1 revolution per second. So now the balcony is directed vestibularly, and the second implant that can also be used for internal sinus lift, because we have a huge defect distally, and also this defect is filled up with PRF and is completely closed in order to achieve this parasol effect. The apical mattress sutures following Simon Pieri's technique is very important here, so that we remove all the tension from the wound. Here enlarged you see the parasol that is then covered with the gingiva. Another case, 1-1 late implantation, 2-6 late implantation sinus lift, and 4-5-6 immediate implant directly after the surgery. And here the images once again. And you see the balcony 4-6 that goes over the mesial alveole. This is used as the parasol. Here the situation after healing, 4 months later, crowns directly after inserting. You see that the situation looks perfect and no food residues will ever get stuck in there. This is the situation after the insertion, and the patient sent the X-ray from the US. You see that the bone regenerated perfectly. This is a very interesting case because there was a sequel to it. The TS2737 had certain problems, and on the 3D we didn't see any information there. So we left them in, but later on we realized that we have to remove them. But here we see that the bone perfectly developed over the sinus implants, and also in the area of the balcony implant, the bone regenerated perfectly. Interesting here in this case was that we reopened it again. You see the sinus implant, no soft tissue that you always see for titanium implants. So the edge on the implant level, we also see that the window that we only closed with PRF is now completely closed. In region 3.8, 3.7 has already been extracted. We see the nycocavity that is now completely closed. Here, late implantation 1.1, you see a perfect papilla, because such a late implantation is always more complicated compared to an immediate implant when the papilla are still there. In this section, we also see very nicely how the bone regenerated over the balcony implant. The balcony principle, once again, the implant is the tent pole and the disc on the peak is the parasol. Before and after, here with the crown, you see that practically up to the disc, up to the parasol, the bone regenerated without using any bone grafts. Here the front teeth had to be removed as well, a very nice, a temporary. But I show you this movie for another reason. Here a perfect sinus lift, there should be no tension on the sinus membrane. The sinus implant is screwed in. You see the disc. And the window bone is put on top of the disc to strengthen the parasol effect even more. Then we put the PRF membrane on top of that, and that completely closes the window. So you can imagine here, that is easy to understand, that you can reduce effort, risk, and costs. We save €150 for the bone graft, €150 for the PRF, for the membrane. We take the bone of the facial sinus cavity, and in case of a loss, we do not go into the negative, so to say. The sinus will not be compromised, but we will just go back to the normal biological level. So in case of a failure, you maximally go back to the point where you started at. Now let's take a look at this situation that shows very well what you can do with a sinus implant. This is a pre-op state that we took over, now a fixed long-term temporary, and here the final Prosthodontics. You see that the implants healed in perfectly. You have attached gingiva around. And this situation is quite interesting. 16th of February 2017, 4 months later, we see the first lamellar bone that starts to grow out of nothing. And after 8 months, it even looks better. And after 14 months, you have a perfect lamellar bone that you can hardly distinguish from original bone anymore. I think we all would prefer to have this lamellar bone with a good vascularization in your mouth compared to 2 cubic centimeters of dead cow. Let's take a look at the details of the implant. It actually consists of 2 pieces. The upper part is made for maximum stability. As far as I know, it's the only ceramic implant system that is made of 2 pieces where the screw does not protrude the implant area, but where the screw is just on the upper broad tulip area with a width of 1.3 millimeters. In the area of the maximum load, that means the red arrow here, the 2-piece implant is not only massive and has almost the same stability as the 1-piece implant, but here it is even enforced because we don't have a deep thread but a micro thread with 0.04 thread depth. That means a 3.8 implant minus 2 times 0.04 is 3.72. This is the core diameter of a 4.5, 4.6 implant. So for a 2-piece implant, 3.8, we have the same stability as for a 1-piece 4.6 implant. You also see the upper vertical section. There is no thread anymore because this is in contact with the gingiva. And in case there is a bone, then it will osseointegrate. If in the area of the micro thread, gingiva or bone is missing and the gingiva is attached there, so it will attach directly to the zirconium oxide. This is what we've seen before. So the upper section is made for maximum stability and for being friendly to the soft tissue. and also for preserving the compactor, because when I ask for the maximum torque in the area of the compactor, then often I get an answer up to 75. This is of course completely wrong for titanium and for ceramic. We have the same rule as here. The maximum torque in the area of the compactor is 35 Newton centimeters. Ideal torque is actually 0 Newton centimeters, so in the minus area. Compact bone is actually dead bone, is not vascularized. When we drill, we see no vascularization, no bleeding. So if I just apply some Newton centimeters of pressure, we will compress the compact bone even further. And based on Mamoto's law, a Japanese researcher made very nice studies with regard to pressure on tissue and the decreasing vascularization. We will destroy the compact bone here, and after some weeks, months or years, we will see a decrease in bone that looks like peri-implantitis but is non-inflammatory just because of the pressure. So here in our concept, you will see that when you see the drilling protocol later on. In our concept, we take as a last burr the so-called countersink. So the shape is identical to the upper section of the implant, so no compression can be generated. And this is the lower section. This is where you have the power. We have a tapered core or a conical core that pushes away the soft bone, and we put on top the dynamic thread. We have a thread depth of 0.375. We have just an inclination of 7 degrees. That means, and you might see that here, when you compare it to other implant systems on the market, we have the highest share of surface with the same implant diameter and length. So down here, we work with compression, except for bone class 1, but I will show you that later. The most conventional systems work with thread cutters, but it doesn't make sense because in bone class 1 we screw in the implant, we have a high primary stability. But when we work with bone class 1, we have the less vascularized bone, and it doesn't make sense here. So in our SDS system, it makes more sense. So less torque in bone class 1, a bit more in bone class 2, 3, and 4. So our drilling protocol is also based on the bone classes. So in descending order 4, 3, 2, 1, you use the drills. Bone class 2 implant still has too much of torque. You remove the implant, use bone class 1 then, and then you should be able to insert the implant. So every bone class has a different protocol that depends on the hardness of the bone, and this makes sense because you would also use different drills for steel or wood. So why not doing that in an even more sensitive material like bone? Let's take a look at the drilling protocol. Bone class 4 means that here we use a small counter, just open the compact bone without compression. And whatever is transparent here is compression. So this is the bone condenser that is integrated. Bone class 3, the main difference here is that we use a counter that has the same shape as the upper part of the implant. So no compression here in the upper area, but a lot of compression in the spongy bone. Bone class 2 is the simplest bone. Every implant works here. The most complicated bone class is bone class 1, because here you hardly have any vascularization. It's almost dead bone. So here it's very important to prepare overdimensionally. This is shown here in pink, and you see that the thread tips only are inside the bone to 0.15 millimeters. And all areas that you see in pink here are cavities. That means the bone is not touched. So even if the thread tips overheat, and the risk for ceramic is higher here because of the friction, but the heat does not dissipate to the core like for titanium implants. But here in this case it cannot happen because of the cavities. These are kind of biocontainers, like our colleague Fuchs would have said. So when we take a look at the histologies there, then you see very nicely that it works quite well. And whatever is pink here will become new lamellar bone. And this has a much higher potential to survive in the long run due to the vascularization compared to the compact bone. What happens if we don't have a gap or just a small gap, according to Lemons et al.? Well, then we just have some bone cells in between, but we don't have a vascularization, and all this just works very slowly, 1 to 3 microns per day. If we have a large gap, then we have a directed growth with blood vessels, callus formation, 10 to 50 microns per day. And you see that the highest potential to form new bone is directly after the extraction, because then after extraction the whole system is directed to generate new bone. And this is why we say it makes sense to insert the implant then and not to wait until the bone formation activity decreased completely. And then we have to wake it up again. This is an overview of the prosthodontics. This is what the implants look like when they are healed in. They protrude for 1 millimeter, and this is okay for being able to set the crown. And here you see that we try in the abutment, we decide how to put it, and then abutment and screw are inserted. You can only use cement as well. I use both, cement and screw, just to be on the safe side. And also the reason is that I don't want to wait for 1 or 2 minutes and put my finger on until the cementum dried and hardened. We use Ketak here. And when you put Ketak on zirconium oxide, you cannot even remove that with ultrasound. So there are high adhesive forces here when you use Ketak and zirconia oxide. Now a red ring diamond is used. I start in an oval form. It works very smoothly. We don't put any thread around. We don't need anesthetics here. If we touch the keratinized gingiva, it doesn't hurt because there are no nerves. Then we change to a torpedo and we put the edge directly on the gingiva level, maybe 1 or 2/10 subgingivally. If you'd use retraction threads, then this would of course lead to retraction. This is why they're called like that. and to have then to prepare subgingivally. But if you don't use any retraction threads, you don't need subgingival retraction. We have not been using retraction threads for 10 years now, and we achieve perfect shapes. And we keep the gingiva healthy, because when you know that gingiva attaches to ceramics, so here to stop the bleeding, you see. So when you know that, we should not put anything between the gingiva and the ceramic implant. No scaler, no thread, nothing. This is what Chemlock said years ago: one abutment, one time. Now I place long-term temporary. You see how the mold is inserted, then to achieve the right height, the patient bites on it. That with a scaler I remove the excess material, and before it's completely hard, the LTT can be removed. You can cut off the excess material with some scissors, then put it back on again. The patient bites on it, and then you can use flow to strengthen it. It works until 20 minutes after Luxatemp was used. I prefer it over ProTemp because it doesn't distort. Then I use the oval diamond and remove all the friction, so the edges should be perfect. Also, later with the Prosthodontics, we don't have any friction, because otherwise you put pressure on the bone, on the implant, and also on the superstructure. Also, when you insert it, the patient should never bite on cotton wool.
Während der Zementierung gearbeitet werden. Sie sehen, ich verwende hier im Prägum perfekte Ränder.
Or you should never put a lot of pressure during cementing. I use impregnum here, perfect edges. You don't need any thread here, as you can see. You can also use silicone, hydrocolloid, whatever you prefer with Durolone, not Setac, please, because Setac cannot be removed from the implant. You will always have Ketac on the implant, then you should only use that for the final restoration, not for the LTT. We use Durolone, no pressure during hardening, because then you put pressure on the bone, permanent pressure on the bone. So here you see no friction at all on the final crowns. Just close the teeth slightly. You can remove the foil without any pressure, and if the patient closes the teeth with pressure, then the foil sticks. So you have lower occlusion here, that only after using the resilience of the own teeth, you have contact to the implants. Here, Ketac is used, no pressure, in order to put no pressure on the bone or the superstructure or the implants. Occlusion is tested once again with the own teeth, with the implant crowns. So if the patient bites heavily, the foil sticks. And this is the final restoration then. Now another case, one of your colleagues, she came accompanying her husband, and throughout the course she came up with the idea that her dental state might be responsible for her health issues. And actually, she had heart problems and a stent should be inserted. And these are the X-rays that were done during the course. And here you see the post-op image in the frontal area. LTT is placed intraoperatively. You see that huge cysts were removed. Here we had huge defects. We used balcony implants. And when we take a look at her health state, well, this was the picture directly at the day of surgery. 5 months later, she sent the image. Now she is opening with her husband a clinic for biological dentistry and ceramic implants in China. She's working again. And in summer 2017, she sent me this testimonial where you see that she didn't have any allergies anymore after 40 years. And that the heart surgery was not necessary anymore. Yes, I think this shows very nicely what we can do with the Swiss Biohealth concept, that we have also written that down, that we teach at our Swiss Biohealth Center here in Kreuzlingen, together with SDS, Swiss Dental Solutions. We have the Swiss Biohealth Clinic and then the Swiss Biohealth Solutions. And on 2,500 square meters, we prove that it works. And the colleagues are, of course, invited to visit us anytime, to accompany our surgeries. We also do some streaming out of the Biohealth Clinic. You can also have a guided tour, or you can watch full HD videos of live surgeries. So I have a camera attached on my glasses, so you see exactly what I see during the surgery. Yes, I think that gave you an overview of the Swiss Biohealth concept. And these are some impressions of the Swiss Biohealth Education Center. You can visit Education Swiss Biohealth or use the links of the SDS Swiss Dental Solutions website. Can get some more information on hands-on courses, live surgeries. And we also have different speakers that we invite that come to our education center. And I would be happy to see you soon there. So goodbye from Kreuzlingen. Goodbye from the Swiss Biohealth Clinic. All the best.